Hi, everyone. Welcome back to another episode of Forward Physio, the show that is dedicated to pushing the profession of physiotherapy forward by having conversations with experts around the world and educating and empowering clinicians. My name is Noah Mandel, and today's guest is Dr. Chad Cook, who is a professor and physical therapist at Duke University in the United States. Chad has 35 years of clinical experience and 25 years of academic research experience. His primary clinical and research focus involves the management of musculoskeletal disorders, with over 400 scientific publications, 50 editorials, 4 textbooks, $11 million in external funding. Dr. Chad Cook is one of the most prolific scholars in the physical therapy profession. Chad is a recipient of some of the top awards in research, teaching, and service in the profession of physical therapy. Chad is very well known for his research in manual therapy, and today what we discuss is what should a modern curriculum look like when it comes to teaching manual therapy. I know that when I was in school and in schools all around the world, there are a lot of confusing and conflicting ideas about manual therapy. And I wanted to have a conversation with Chad to try and clear the air a little bit. Chad is also very knowledgeable about why certain treatments may work and how much they work. So in this conversation, we discuss things like the placebo effect and manual therapy, who may benefit the most from manual therapy, what specific treatment effects manual therapy has to offer versus what effects are a little bit more non-specific in nature. This was an incredibly insightful conversation, thanks to Chad. And without further ado, I'll let you listen to it. So here's my conversation with Dr. Chad Cook. Like placebo, I think you'll walk away from this conversation. Hi, Chad.
Hey, Noah.
So having learned so much throughout your career, whether it's from the hundreds of publications or your teaching or your 25 years plus of being in clinical practice, what are some of the most important values or skills that you would want to instill into a new physical therapist?
Curiosity. And I think that's what, we lose a lot of PTs earlier in their career, I think, when they get out and things get mundane, or maybe they're challenged by, the day-to-day clinical practice, or they don't see the gains that maybe they were taught that they would see in school. And curiosity allows you to continue to peel away the layers on why you're seeing the outcomes you do, or why is it that some people improve and some don't. What can you do to maybe improve that piece? I would say that for clinical practice, and I would say that also for research. When researchers lose their curiosity and they start just basically writing grants to get money, you end up with so what studies. So definitely curiosity is the first thing for me.
I love that. When I was a student, I was quite curious, and I think it came from a point where I made a lot of mistakes prior to physical therapy school in terms of just my health literacy and what I believed. I believed in a lot of pseudoscience. So I think I already went in pretty inquisitive. And the reason I wanted to have you on today was to chat about a lot of the thoughts that I was having about our manual therapy curriculum. And it started off with the lesson that the effects of manual therapy are non-specific in nature a lot of the time, or maybe they don't have so much to do with the specific technique. That was in the classroom. And then we would go into the lab and we would learn really, really specific techniques, and everyone was concerned that they weren't applying the techniques right and we weren't feeling the joint move correctly. And it felt like there is this mismatch there. So I wanted to talk to you today about what you think goes into a more modern manual therapy curriculum, and whether that was the right way to teach it, or whether you have thoughts if there would be a better way.
So I have many thoughts, and I'll try to be brief. But first of all, what you encountered and recognized is something that multiple people have. And it's like, why are we spending so much time learning a psychomotor skill in lab? And when the specific aspect of this particular technique hasn't been shown in trials to be that important. And it's a great question. So I'm going to try to break it down and just, cut in whenever you need on this. So we've studied this, and we too have seen a need to change the curriculum. And there's a colleague of mine, Damian Keeter. He was my PhD student, and he's gone on and has just done exceptional things. So we did 2 Delphi studies where we tried to get the experts to provide a consensus-based approach on what needs to be removed from a manual therapy curriculum and maybe what needs to be added. And we published 2 papers within the last 3 years on this. And unfortunately, the consensus was we need to just add things and not remove anything. And that's not the answer we were looking for. So I've been part of a couple of other papers, one out of Great Britain that looked at a modern way of teaching and saying it's more patient-centered. We should be very careful what we say to a patient, give patient options, those sort of things, very similar to a patient-centric approach. And then on another paper that is really more around, how do you frame this approach to a patient? What is actually happening? Is it really important to be specific with your approach? Do the trials actually tell you enough to suggest that you should be non-specific? All of these things. The truth is that there are a lot of truths. So the first one is that these non-specific findings are in average treatment effect studies. So in an average treatment effect study, you have some people who really benefit from a specific approach. You have others who do not benefit from a specific approach. And then the folks in the middle who, it doesn't really even matter. And when you have something like that and you compare 2 groups, specific versus non-specific, you rarely ever find a significant effect. So there are going to be instances, maybe when you're working with cervicogenic headache or something like that, where it is going to be more important to be specific with your approach. Whereas looking at low back pain, non-specific, it's not going to matter a bit if you're specific. There are going to be instances where the dominant pain mechanism probably suggests you need to be a little bit more specific with your approach. If a person has a noticeable neuropathic pain, you probably want to be very careful with any manual therapy technique with that. Versus nosoplastic pain, the data actually suggests you should not be specific. You may be worse if you're on the guilty segment, etc.
Interesting.
So I can see why it's confusing to everyone, and it is. But certainly there's enough evidence now to suggest that spending multiple hours of education to learn 10 specific treatments for the thoracic spine probably isn't the best use of our time. That maybe you have 10 to 12 techniques that are pretty good, very safe, that you as a practitioner, you do well with these in your hands, and then spending more time on the external aspect of what does this actually do? How do I frame this with the patient? How do we follow up with this in a home program? How can I convince them to also do active treatments? That should be part of the training process, I think, more so than just the psychomotor stuff.
So on the note of the psychomotor stuff, you mentioned that the emphasis should be more so on just sort of feeling good with your hands. What do you think makes a good manual therapist in terms of the psychomotor skills? So in terms of their actual hands-on abilities.
That's a great question. I think so if you've ever worked with somebody who really has good hand skills, I mean, you can differentiate that person from someone who maybe has iron spike fingers and really doesn't manage things very well. And I mean, it's no different than in the field of psychology, people who really have the ability to converse and dig deep into the problem. Peter O'Sullivan is a person I always think that if you ever hear him interact with a patient or interview a patient, his skills are remarkably good versus other people who may not have that skill set. So what makes a person good? I think just comfort in what they feel with the tissue and an understanding of what the expectations are when they work an individual, whether, with their neck or their back or whatever. safety, where they perform the least amount of force for the particular technique for the benefit they're looking for. And always being like a lawyer, you never ask a question that you don't know the answer to already. So you know what the outcome is going to be before you actually apply that approach.
What do you
I
mean?
think that you never say, hey, let's try this technique. I'm not sure what the outcome is going to be. It's either going to be good or markedly terrible. You always have an understanding when working with a patient that they're probably going to do well with this particular technique based on your clinical experience, and it's a safe enough technique that the person will, their tissue will tolerate it. That's what I mean by that. And lawyers will say that you never ask a question in court that you don't always know the answer to because you don't like surprises during that court appearance. Manual therapists should feel the same way, I think, about the way they manage patients.
I imagine a new grad would feel very confused and unsure about when a patient would respond well and when they may not. And you mentioned that there's perhaps certain drivers of their pain and disability, like whether their pain is a more nociplastic or neuropathic profile. What are some other perhaps predictive factors that we can think about in the clinic to judge whether or not a patient would respond well to manual therapy?
Unfortunately, if you look at the literature, there's not a ton. And they have different levels, right? If you look at the moderator analyses, there is some findings that, if a person hasn't had a past history of spinal manipulation, believe it or not, it's the opposite of what one would think. A person has high levels of pain, they tend to respond a little bit better. In a moderator analysis, it suggests that they should receive manual therapy and not something else. Now, there's all kinds of just prognostic factors that suggest they might do well. Like if they show a within and between session change, if they, shorter people tend to do better with manual therapy. Men do better than women.
Shorter people?
Yeah. These are, again, not very valuable, small moderating effects.
Yeah.
And it doesn't mean that they're going to benefit from manual therapy and not something else. It just shows that if they had these characteristics at baseline and they received a manual therapy approach, the outcome was actually better. To really look at the literature the right way, you would need to look at moderator analysis, and there just aren't very many of those. So we really don't know who are good candidates for manual therapy.
Okay. So right now, would you say that it's safe to say it's mostly based off of clinical expertise?
I would say if you polled the average clinician, probably 99 out of 100 would say that, yes.
Okay. It's tricky, especially when you don't have a lot of clinical expertise.
You know something? We have parallels in health, right? We have surgery. They also, if you look at moderator analyses for surgery, there's almost none. And to me, that's a higher stakes approach to care for not actually having any data-driven elements. And even moderator analysis for exercise are not that strong. So we're not good at any of that. And cognitive behavioral therapy also not any good at predicting who's going to respond with that in the right way. So it's, manual therapy is basically in a bucket with a lot of other things. And when you start looking at more costly, invasive, potentially harmful elements, then I think it gets really important. And I think that's why a lot of manual therapy researchers have been leaning lately so much towards safety. Do what's safe, and then kind of decide what to do after that.
Right. Since we don't have the best idea of who will respond well, might as well make sure it's safe and not something as invasive as a surgery, because there's a lot less harm. Got it. You mentioned those Delphi studies where Damien Keeter and yourself and some other colleagues interviewed a bunch of experts to see what they would want in a modern manual therapy program and what they would want to omit. And you said there was not a lot of omitting, but a lot of wanting to add things. What were those things that they wanted to add?
It was more modern things like pain science, an understanding of pain science, which I think has really caught hold in the last 10 to 15 years within our profession. an understanding of the different dominant pain mechanisms and how you might treat differently based on that. Those are the big ones. And then patient-centered care was another one. I mean, although I would argue that patient-centered care has been part of a good clinician's approach for decades, the concept recently has really caught hold and has been promoted, I think, quite a bit, including in manual therapy.
Right. And that makes sense to me, and I think that was all present in my curriculum. Right, this patient-centered approach, the idea of pain science, and that our techniques don't always work because of how specific they are. But I found that the issues that troubled me within the curriculum were probably due to things that were not omitted. Right? We still had this overemphasis of highly specific treatments, and we did touch on that earlier on. Would you like to dive into that a little bit more, or are there other things you think are important to discuss about what should be omitted from a modern manual therapy curriculum?
So there are many things I think should be omitted, and have talked about these before. I certainly think that learning 10,000 techniques is not a necessity. Again, I mentioned before, you should be probably an owner of 10 to 12 techniques that you feel comfortable with. And you're going to do fine with those. I think the history of manual therapy and being wedded so heavily to that history, not interested in going there. There are still many clinicians that will talk about concepts and philosophies that were created about 100 years ago. Wow. before we had science to really test those. There's a lot of paradigms when people try to explain why manual therapy works, which haven't withstood modern science. It's time to divorce ourselves of those as well. And that's not a bad thing, right? We were basically the pioneers of manual therapy. Were doing what they knew. They saw something in the clinic. They didn't have the sophistication in science to actually understand what it is. So they made theories to do that. And some of those theories have not held water. So that piece should probably go. I think an understanding of, this is something I would add, but an understanding of mechanisms and what is actually happening based on what we know should be added. And it's quite different than a lot of the theories that you may have learned in your education, or if you go to a Con Ed course or something like that. Those kind of old school mechanistic theories can probably go. And I've said this 1,000 times, and I don't mean to be offensive when I say it, but just the elitism around manual therapy that, if you study this and you're a manual therapist, you're going to be a better clinician than everybody else. You're smarter than everybody else. That was kind of a pervasive thing 30 years ago. And not so much, I think, now, but there's still some carryover from that.
Yeah. I think it also goes the other way. Sometimes clinicians that think that they omit manual therapy altogether think they're more elite and smarter than manual therapists.
Oh, there's been a big trend of that. And in many cases, the folks that are omitting things don't fully understand what it can do and what is happening and what that might lead to. And that's okay. Everybody has a choice, but a lot of the research we do looks beyond just a single intervention, but also that encounter with the patient, the experience with the patient, whether you're matching patient expectations, those sort of things. And there are expectations from our patient population about what a physio encounter is supposed to be like.
Yeah, there's I think 100 different directions that I want to take this conversation in right now, but let's go along the lines of patient expectations. So from that, one of the Damien Keeter studies on person-centered care and modern manual therapy, can I read you a quote from it?
Sure.
So it says, pharmacological intervention, exercise, manual therapy, and pain education have all shown to be less related to the specifics of the intervention and more related to the specific response intrinsic to the patient. If response is dictated largely by patient-specific factors, it is time to put the patient at the center of the care plan. How do we do that? How do we put them at the center?
I think you have a conversation with the patient, try to meet them where they're at. Very similar to if you have a pain neuroscience approach, really understand what is making up that patient's pain experience, what are the factors related to that, what they've had before, what they believe might be a contributor, what they're willing to do on their end of it, and kind of meeting them in the middle with that. I think that's probably the best way to go about it with what we have right now. I know that in that paper, conceptually, what we were talking about was the fact that people respond very differently even to efficacious treatments. That often you would try a pharmacological approach with somebody and it's worked with somebody before and it just doesn't work for that particular patient. You try something else and it does. And that's actually more the norm than the exception. And I think that's hard for a lot of new clinicians or maybe seasoned clinicians who have a very myopic view on how to manage somebody. The recognition that there's great variability in outcomes, even with good approaches. Once you understand that, it takes a load off, I think, as a clinician. And then you realize that there's going to be some give and take, and that you may have to change your approach with that patient in front of you, or dig a little bit deeper to find out what might work for them.
Yeah, it's a fascinating, and I agree with you, a liberating idea as well. We're speaking about patient expectations and predictors of who may respond well to manual therapy. And I know you mentioned there's not a ton of great research answering that question. Do you hypothesize that patient expectations play an important role in their outcomes?
I do, and I want to just preface it by saying that it's not just manual therapy; it's any of our treatments, and it's surgery too. There's nothing that's completely clean with respect to that. I think manual therapy gets singled out quite a bit because it's a popular thing to take shots at, but in reality, it's a lot of different interventions, including joint replacements. And we just finished a trajectory study, found great variability in the outcomes with a joint replacement, and joint replacements are about as standardized as you can get as a treatment. So I apologize. I forgot your question, Noah.
Just how important patient expectations are, and what if you believe patient expectations are important predictors of outcomes.
I do. I think the challenge is how do you measure patient expectations accurately? So there's a really wonderful paper in 2010 where they looked at the construct validity of patient expectations, and they found that at that point there really weren't any good tools that truly captured kind of the essence of expectations of a patient. And expectations are going to be probably multidimensional, right, in their interaction, versus just a single construct of, oh, I expect this to be good. We did a trial and finished it up in 2023, published it in BMC musculoskeletal, where we actually measured the role of patient expectations. And we used the modems tool. And no, it was just a worthless study because everybody had really high expectations. So there was no variability in the expectations at all. So when you have nothing but great expectations, you can't really study it in a research study. You need something that really better filters out those who have lower expectations, or maybe captures those that are in the midpoint. And that's one of the problems with what we have with patient expectations right now. So if you see the literature, the results are actually somewhat mixed. There's quite a few that suggest that, patient expectations are going to influence the overall outcomes, but the ability to really look at how strong that effect is highly dependent on how it's measured.
Right. So that's in a research setting. How would a clinician sort of dictate their patient expectations? Is that just common sense? It's through a conversation and blatantly asking them, or should we try and be a little bit more discreet in how we pick up on these things?
No, I think you actually have to ask them. And in that patient-centered encounter, one of the things that you have to do with your patients is talk a little bit about what you've had before, what seemed to work, why didn't it work, or why did it work. You probably went on to Dr. Google and looked this up. I mean, which way are you leaning? What are your thoughts so far about what you know about the condition, what you've been told, what you've been imaged? What are you thinking? And then that allows the patients in an open-ended statement just to give their thoughts and beliefs about what might be beneficial for them. And then in those cases, you might get some golden comments from them. Like, I just feel like I'm not strong enough, and it would be, I don't know how to strengthen this particular area. If there was a way I could do that safely, that wasn't painful, it seemed to me that would be beneficial. Those are the kind of things that I look for. I don't use a tool. I don't think the tools are that effective, but I do have that very open-ended conversation about what that patient believes.
Right. If we are dealing with someone who is very honest and open about their expectation and what sort of treatments they desire, I've heard some clinicians argue that we should always be picking the most efficacious treatments. And I've heard other clinicians argue that we should meet the patient exactly where they're at and offer them whatever they're expecting and desire, because if they're expecting and desiring those things, then maybe they'll have a better outcome if we give it to them and meet them where they're at. Do you think the answer lies somewhere in the middle?
I don't know the answer to that. And I've heard the same. I've heard some people who are very steadfast, and it's like, I will only do this. And if you want this, then you probably don't want me as your clinician. Whereas others are more, try to build that relationship with the patient. Sure, we'll give that a go. Let's also do this. Let's use the 2 or 3 combinations together, see what happens. I look at the big picture. When I look at that, I look at whether that patient is going to continue working with you. We've been looking recently at just the plethora of no-shows or cancellations that we often see and the reasons why. We've got a paper coming out very soon that looks at why people come for one visit and don't show up again. And there tend to be 5 reasons for that. One of them is they didn't see the value in PT. They didn't. And another reason is the therapist didn't really listen to them and their point of view and their thoughts. So those pieces are really important if you want to continue to work with that patient, if you truly believe that therapy is something that might be beneficial for that patient. So I look at it that way. So I tend to give and take a little bit. I worked with a guy one time at a rotator cuff repair, and he was a huge believer that ultrasound prior to the strengthening approach that we were putting through was a necessity. And I could sit there and argue with this old fella who had a rotator cuff repair, or I could roll around the ultrasound head for a little bit, knowing that it's not going to really make a difference. So in those particular cases, I look at what are you going to win, what are you going to lose, and kind of move on from there. It's patient dependent.
Yeah. How do you explain ultrasound to someone like that? I'm not trying to say that you're trying to dissuade them, but when you're applying it, I know personally, if I'm not a big believer in a treatment, it's difficult for me to administer it because education is very important to me. And I'm constantly having a dialogue with the patients about why we're doing things. So what do you say when you're giving someone ultrasound?
So it's probably not going to do anything, but if you believe that it's going to, then we can certainly give it a go. And
right.
And I know in a previous podcast you talk a little bit about the placebo effect.
Yeah.
So ultrasound does have a specific effect. It heats the tissue up. It has a very small effect toward pain relief. And it's important to recognize too that placebo and placebo effect, 2 different things. Most people think they're the same thing. Placebo effect should probably be renamed a catalytic effect because it boosts whatever effect that's present, makes it either bumps it up or it bumps it down, and that would be a nocebo. But in that particular case, if they believe that it's going to reduce pain and allow them to exercise with less concern and with more vigor, then, on my end of it, I don't have that big of a concern. I'm not going to bill them for it because it's, I don't think it's doing anything.
Mm-hmm.
But I'm also not going to be, I'm not a hardliner when it comes to
Mm.
that. I think therapy is a relationship, and, getting the patient involved is better than not getting the patient involved.
Right, right. Is manual therapy a placebo?
No, I think because it has a specific effect.
Mm-hmm.
The challenge is it has like 1,000 specific effects. We don't actually know um, the true. If we don't really know exactly which of those specific effects are the ones that lead to the patient-reported outcomes.
Mm-hmm.
So about 3 weeks ago, we published an umbrella review in PLOS ONE. And again, Damien Keeter, first author on that, he was working on that study for 2 years. It includes thousands of studies that have looked at animal, preclinical, and human related mechanistic outcomes and what actually happens
Mm.
with the application of different forms of manual therapy. There's quite a bit that actually happens to the body. A lot of it is pain relief components, but there's anti-inflammatory, neuroimmune, a lot of other elements. Again, what we don't know is what elements of those mechanisms are responsible for the clinical outcomes that we see in trials. And that's really the next step. That's a causal mechanisms trial.
Mm.
Those are really expensive to do. I can think of maybe one that's looked at that. What we have is a lot of just, I'm going to do this technique and then measure what happens to the body. And
Right.
we see that with exercise. We see that with a lot of other things too. It says the causal mechanisms trial is really the holy grail of what we want to do.
Yeah.
So is it a placebo? No. Does it have a placebo effect? Probably a pretty strong one, I would argue.
Mm.
Especially putting hands on patients, and especially if they want that piece of it and they're not getting that anywhere else, it's likely to amplify whatever effect is present, and 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 that could potentially be what leads to the clinical outcome.
Yeah. I find it very important that we're distinguishing between placebo and placebo effect, but also between specific effects and then actually quantifying how much those impact patient reported outcomes. Because I find a lot of the time when we're talking about specific versus non-specific effects, we sort of immediately assume that that implies we're also talking about the outcome that we're getting.
Yep.
But I'm sensing that when you're talking about specific effects, it's not as if all of them will lead to a patient-reported outcome, right?
100%.
Yeah.
And we wrote a paper on this. It's in the International Journal of Osteopathic Medicine. Really, it was a call for action paper because a lot of the NIH research dollars go toward associational mechanisms research, especially around manual therapies, acupuncture, and other components. And just to give a difference for your listeners, so if you do an animal-based study, and let's say you damage the hind limb of a mouse, and then go in and do different types of acupuncture, you can measure the mechanisms that occur with that acupuncture.
Mm.
But that's an associational mechanism study. It's not telling you if that acupuncture is going to be causal to the improvement of overall outcomes. First of all, it's an animal study. They don't have patient-reported outcomes. You would have to do this in a clinical trial with humans who actually have a disease mechanism, and then use the right type of design that actually measures how much that specific effect is responsible for that clinical outcome. And we write about that in the paper. We said it's time to start doing these. This is where the money should go. This will give us a better understanding then of how truly our interventions really do work.
Yeah.
And it might give us, there are 20% of people who get a knee replacement have either no improvement or a worsening of outcome. Wouldn't it be nice to know how that surgery interacts with the body, if there's something there that would allow us to understand how it's going to influence the clinical outcomes? We just don't know that.
Yeah, I'd say so. It would be really nice to know that. And I was about to say before you mentioned the knee replacement that this isn't just about manual therapy, right?
Oh,
It's
no.
about all of our treatments.
I mean, the great unknown, right, is cognitive behavioral therapy, because it first of all, it impacts people so differently, and what actually is happening. And most of the stuff that we measure with that is patient reports, indirect mechanisms. We don't actually know what's happening in the brain or in the tissues, etc. In most cases, and if we understood that and understood what to look for maybe earlier, and to help us identify candidates, again, a holy grail of research, and hopefully we'll move in that direction soon.
I know it's really, really difficult to say this, but assuming everything went according to plan and researchers around the world decided to hop on board and start focusing on this, what sort of timeline are we looking at before we have some more answers that actually change what we're doing clinically?
That's a great question. I will say this. I talked to somebody really smart. I spoke at a conference in Switzerland, and afterwards I was walking away, and the person intercepted me, and they said, I appreciate what you're doing. I appreciate, your suggestions, but I don't believe it's ever going to happen because it's too complicated. And if you think about mechanisms, as I mentioned in Keter's study, there are thousands of different mechanisms. So we can measure these independently, right? Let's say we measure some inflammatory biomarker. And the problem is that thing doesn't work in a vacuum. It interacts with multiple other biomarkers. And the interaction is often different depending on the application or how it was applied or the person themselves, their physiology differences. So understanding all the different contributing biomarkers and the interactions, I'm not sure we're ever going to know that. I'm a big Star Trek fan, and the original series had a tricorder, right? They go up and they scan somebody, and they said, this is what they need. And the naive me from 35 years ago when I first started as a PT believed that, we'll get there someday. I'm not sure we'll ever get there because I think it's so complex and there's such great variability in patients.
That's an unfortunate answer, but I appreciate
It's gloomy.
the honesty.
Yeah. I'm just being honest.
I appreciate it.
I will long be retired before this is completely sorted out. I'll just say that.
Okay. Well, let's get into, I guess, more of an ethical conversation then. I don't know if we need so much evidence to talk about that. When it comes to administering treatments that we think are placebo, in hopes of deriving a placebo effect, do you think that that's something that is ethical? You did mention the ultrasound, and I know you said there is a specific effect of ultrasound, but let's say we have a treatment that we think doesn't have an actual treatment effect, and we give it to a patient, and we tell them that it's going to make them better, and it does because we told them that and they believe it. Do you think that's ethical?
No. And so there's where I draw the line. In March, I was at the Complementary and Integrative Conference in Seattle. And I'll say this for starters. They've done a lot of research around some of their integrated approaches, and they do have a specific effect. Many of them do, but some don't. And in those particular situations, I cannot advocate for administering that particular intervention that has no specific effect, no actual mechanism that could lead to an improvement of overall outcome outside of a placebo effect. I would not advocate for that. I think we need to clean up the shed and not have those elements. And as a profession, I think physio's done a reasonably good job of, moving away from those things that either have trivial, small, or no effects, and then pushing more toward those that have small to moderate effects. In effect, if you had to throw something out there that appears to have no specific effect or a mechanism to its application outside of a person's belief and placebo effect, K-tape might be a good example. I would never advocate for K-tape. I would just say it's really not doing anything but taking your money on that. I think you in a previous podcast had mentioned crystals. I mean, that I have no belief in crystals.
Yeah.
It has no specific effect or anything like that. Magnets have fallen into that category too, from my understanding of the literature. So I think we draw the line there. If something does have an effect, then it can be part of a package. If it's the only thing you're doing with the patient, I think there are ethical considerations with that as well.
Do you mean if there's a particularly small effect?
Oh, if you're using, let's say ultrasound is the only thing you're doing with that patient,
Yeah.
ultrasound or maybe some sort of thermal agent or whatever, and we know these have trivial effects overall toward the overall patient outcome. I think that gets into, and ethical concerns as well.
Okay. What are some other treatments, just so that the clinicians are aware of what may just be a placebo or have a very, very small specific effect? Or
Well, I probably
treatment effect, I guess, would be more accurate.
Yeah. I mean, I know the ones that have more of a, that actually have a treatment effect versus those who have no effect because that's not really my area. Like acupuncture actually has a treatment effect. It has a specific effect. It has a mechanism associated with it. So I know a lot of people dump on acupuncture, but it actually does fairly well in the literature. Um, but I would say, you know, I would say probably the thermal elements have marginal effects at all, and might be used initially during an acute stage to get somebody over the hump, but shouldn't be part of a planned intervention. But outside of that, I mean, I'm not going to say shortwave diathermy because I've seen literature that shows that it has an effect. Again, it's going to probably be trivial. Um, Yeah, I think those we most of our stuff has small to moderate effects.
Right. So anything that has more than a moderate effect in physical therapy?
In average treatment effects meta-analyses, the three biggies that tend to come up as having small to moderate effects are exercise, a kind of an umbrella cognitive behavioral treatment approach, and manual therapy. Those are the three big ones for musculoskeletal care. I haven't seen anything that has a large treatment effect. If you look outside our profession, generally joint replacements will have like a 1.0 effect, which would be a large effect because the average treatment effects tend to be very good, especially for the hip. Most people tend to do moderately well with that. But other than that, most things are kind of in that middling range of small to moderate.
Right. Okay. Let's say we step out of the world of averages and we're looking at individual responses to different treatments. You mentioned people can vary greatly in terms of how they respond, even to an efficacious treatment.
Yeah.
Let's say we're doing something with a treatment with a fairly small effect, and you have someone who responds very, very well to it. Is a large part of that just because of individual factors that are not related to the treatment? Are those things that we sort of measure separately from the specific treatment effect?
That is what's hypothesized. I would argue that we don't completely know why we have such variability in the outcomes of our patients. And you I think on one of your previous podcasts you talked about the biopsychosocial model. There could be social factors that influence that function as moderating elements to that particular outcome. There could be psychological factors that are mediators to the outcome you see. And then there can just be a litany of different biological responses in that patient. And also there could be non-specific effects, things that aren't even related to the treatment at all, just like time, that could be related to that too. Probably the safest thing to say would be we're not sure. It's probably a cacophony of individual factors with that patient. It could be environmental factors, and it could be just non-specific components that have just allowed that patient to make a change on their own.
Right. I suppose looking at every other variable and just from a probability standpoint, picking a few of those seems more likely. I do just wonder if the specific treatment effect itself can differ in different people, just based off of their biology.
Indeed, it can. So, and I would expect it to for sure, right? Just on, and if you think about different types of, let's say osteoarthritis, which is a great condition that we think we know what's going on, but there's actually a wide spectrum of different related problems with that. So the intervention is going to affect that quite differently in different people, depending on where they're at in that spectrum.
Right.
So yeah, I would argue that specific effect will be greatly different depending on the individual. You can, so there is a proportion of contextual effects trial that you can do. The challenge is you have to have an intervention that has a specific effect. You have to have a true sham as a comparison group. And then you have to have a third group, which would be a no treatment group. And that accounts for the natural history piece that's often embedded in non-specific effects. And then you can go in and actually look at groups, at what is the true proportion of specific effects that led to the total treatment effect on the outcome of the patient. Those are tough to do because you are giving a bogus or sham treatment to somebody. And then the other group, you're just neglecting them and letting them kind of ride along. We have a grant that we've submitted for this, and hopefully we'll get it. But that'll give us some perspective of what the true specific effects are for the intervention we're interested in.
What is that intervention?
It's going to be a manual therapy intervention.
Got it.
There's a big belief that the majority of the overall total treatment effect is contextual in manual therapy. That it's that interaction, it's the belief of the patient, it's it's going beyond what is actually happening with that specific effect. But in reality, most of the studies that have looked at contextual effects associated with manual therapies have only done a 2-arm trial. So they're not accounting for natural history. So we really don't know what the true proportion of contextual effects is, or specific effects, or natural history.
Right.
So we hope we can tease that out.
Okay. So before you tease that out, do we have enough knowledge now of, going back to a manual therapy curriculum, of teaching students and young physical therapists how to enhance the contextual effects as much as possible?
I think so, but not just for manual therapy. I think that would be for any event, right? The challenge is when we talk about contextual factors, and there's contextual factors, there's contextual effects, and we'll talk about that differently in a minute because those are two different things.
Right.
But in 2023, I was a lead author on a paper. We did an international consensus paper on what the heck is a contextual factor, because everybody was talking about these things and throwing stuff out there saying, oh yeah, that's a contextual factor. But there was no common anchored definition. And interestingly, in our international definition, there's actually a lot of things that can be contextual factors, right? There's patient-related variables, there's therapist-related variables, there's interaction between the patient and therapist, there's the environment itself, the setting that the care is provided in. All of these can influence, technically, the total treatment effect. Not all have been studied, but all have been conceptualized to be contributors as contextual factors. A contextual effect is the actual influence on the total outcome from that contextual factor. And that's even studied less. So you see a lot of, and I'm a researcher and I don't want to get too in the weeds with it, but you see these associational studies and they say, oh yeah, this contextual factor was related to the outcome, but it doesn't really give you what the true contextual effect is. It could be very small, or it could be really large. We don't really even know that.
Right. Okay. So in terms of now actually training somebody, I guess as a final closing thought here, unless there's anything else you want to touch upon after this question, in terms of training a young physical therapist, we've mentioned that the psychomotor skills are important, but it's not so much to do with specificity. It's more so to do with comfort and handling and safety. And then we also spoke about these contextual effects and their potential importance in a given clinical encounter. How should physical therapists throughout their career strive to boost their clinical outcomes? Is it by becoming even more skilled? Do you think it's potentially more important to think about the patient-clinician interaction? Are there a few points of emphasis that someone should focus on?
So if I would, if I had to bump up my clinical outcome, my total treatment effect, and I can only invest in something really quick and get a lot of bang for the buck, it would be the patient-clinician interaction.
Mm-hmm.
That would 100% be. Can I give you an example? So I used to work. So I did 10 years of full-time clinical work, and for the last 25 years, I've been in academics. So, the first 10 years, I did everything I could to try to bump up my skill set. Right, I did all the sports med courses, the manual therapy courses, whatever was available, I took it because I wanted to, have better hands, prescribe better interventions, etc. When we looked at clinical outcomes, my clinical outcomes versus a clinician who never did any additional training whatsoever, but she was a cookie therapist. The patients loved her. They brought her baked goods. They brought her gifts all the time. They had these wonderful relationships. The patients would come back and visit with her, etc. Her outcomes were as good as mine. And I just didn't understand it. But she had that therapist-patient relationship piece down perfectly. She listened to her patients. She built that relationship with them. She built that alliance with the patient. She did what the patients needed, not what she thought they needed. And that part made a huge difference. And that was really the first time that my eyes opened about that interaction piece. So if I would train young learners on what to do, that piece would be the most important piece. So Noah, that some people have it and some people don't, right? Some people have that natural empathy. They have that ability to build a relationship with their patient and make them feel like they're the only person in the world when they're with you. That part is almost unteachable. You can teach pieces of it, but if you start with that skill set, you're likely going to see an influence in the clinical outcomes. And that's basically the alliance and contextual aspects about the relationship piece that you see written in the literature right now. That's what I would do.
Yeah. I went to see a new dentist recently, and he told me the same things that a lot of other dentists have told me. But the way that he delivered his message, again, he made me feel like I was the only person in the room. And I told him at the end of the session that he was the best healthcare practitioner that I've ever worked with because of how in tune he was with me. But at the end of the day, he was telling me the same things that other dentists had told me. But now the message stuck a little bit more, and I believed it a little bit more. And that's perhaps a profession where contextual effects maybe matter even less than physical therapy.
I agree. And I love the example, by the way. I have the same example with a new PCP that I have. And I told him at the end, I said, that's the best doctorate I've ever had. And he was just listened, and he was great, and he remembered things. And, those things are important. My colleague, Amy McDevitt, who I've done some research with, has told me this before, and I hope I don't butcher this. She goes, you may have 14 patients on your schedule, but your patient only has one therapist on their schedule.
I love that.
You need to make that one, that visit important. And that has stuck with me quite a bit. And I just think it's really important. And whether you use manual therapy, whether you use exercise, whether you use a pain neuroscience approach, whether it's any of the umbrella components of cognitive behavioral therapy, those fit for everyone and are also important, just as it is for your dentist, even though that's a very mechanical outcome in a dentist, it's still going to have, that contextual piece that matters.
Right. Yeah. I just, the thing I struggle with is my initial gut reaction is going back to almost this idea about crystals. When I think about these things deeper, it makes sense to me, but I would think for the average patient or the clinician who's not so aware of the whole cacophony of different effects that could be occurring in a clinical interaction, it sounds very woo-woo-y, doesn't it? Like if you just listen and connect with someone, then perhaps they'll have better outcomes.
It does, and I think people are looking for something a little bit more tangible and scientific, and maybe someday we'll get to that point where we can actually measure our specific effects. We know we can measure it, we just don't do it. And if
Yeah.
we get to the point where we do the research and actually have an understanding of the proportion of those contextual effects on average, then then we can feel better about it, I guess.
Mm-hmm.
But if we do some things that we know are going to bump up our overall outcomes, and they're easy to do, they're just, it's just part of being a good therapist, then why not do it?
Right. Well said.
Yep.
Any closing remarks, Chad? Things that we maybe have not touched on?
No, it looks like you've gone out on your own, and
Yeah,
um,
yeah.
yeah, congratulations. That's a big step. I hope you have great success. And I read on your website that you have extra time to spend with the patient. I think that's really important, not
Mm-hmm.
to make that person feel like they're being rushed through their care. So I wish you great success with that.
Thank you, Chad. I appreciate it. That's very important to me as well, is not rushing the appointments.
Yeah, and getting something out of it too. You got to get something out of your profession.
Mm-hmm. Absolutely. Is there anywhere where people can connect with you or learn more from you or, read your publications? Anything that you want to link to?
I don't have anything. I have a website at Duke, but it's kind of just an academic website. But I publish a lot, so within a given year, I'll publish 30 to 35 papers. So if you follow, if you go on PubMed, you can see the 1 to 2 papers that come up per month, and that's probably the best way to kind of keep track of what I'm doing. I think we started this talk with curiosity.
Mm-hmm.
I'm a curious researcher. I love just finding things out that I didn't know before. And you would think that after some time things would start getting old, or that I already knew this or something. It isn't the case. Everything is still new, and I'm still shocked at some of the stuff that we find. It's stunning.
Do you feel lucky that you have that,
Oh,
or do you feel like that you're curating that?
oh, I feel lucky. I tell people I am so fortunate that I kind of fell into this, because I get bored easily, and to have the ability to answer questions that you have in a way that can also be meaningful to those who are in clinical practice. What I can't think of a better thing to do. It's remarkable. It's a lot of fun, and I also love the insight. I can. I think it's the difference is that I can sit back and talk about things that are conceptual, or I can give examples, and I can give data, and I can say, well, it didn't work here, and here's probably why.
Mm-hmm.
Those sort of things, I think are fascinating, and yes, I feel very lucky.
Well, I feel lucky that you're doing as much work as you're doing and putting together all the puzzle pieces for us, Chad. So thank you very much for all the work that you do. And thank you for coming on and joining me and having this really, really lovely conversation.
Noah, thanks for having me. I appreciate it.
It's my pleasure.